I have decided to include this video to demonstrate how my phacoemulsification technique has evolved as a result of having the opportunity to watch some fantastic cataract surgeons perform cataract surgery here on ProcedureMD. My total op time has decreased on average from about 11.5 minutes to about 6 minutes as a result of these technique modifications. I start with a clear corneal incision superiorly with a 3mm or smaller blade, with us more recently going to the 2.2mm blades. In this instance, the passing of the blade through the cornea led to some collapse of the anterior chamber, and so we introduced ProVisc and then went back with the blade to complete the incision. I like to use a bent 25 gauge needle for capsular X's, and I sweep from the central portion of the capsule to the lateral portion to create a capsular flap, and then use this flap to create a continuous curvilinear capsular X's in a clockwise fashion. I then like to use the Ozzel handpiece with a flared tip for the actual phacoemulsification, and I like to sculpt the nucleus to create a bowl. Using my technique, it's also very important to sculpt very deeply such that you facilitate the peripheral nuclear material removal, and so I tend to use ultrasound to sculpt pretty deep and then back off and really just use suction to ensure that I'm very close to the posterior capsule. I then like to use the ultrasound to form a groove at the 730 and 430 positions out near the periphery of the nucleus. So as you can see now, I'm going to form that groove at the 730 position and then move over to the 430 position to form a second groove, and then go down to the base of the lens with the handpiece and prolapse that portion of the nucleus between those grooves into the central apical safe zone, and use the quadrant phaco setting to quickly remove this fragment. I then use the phaco handpiece to rotate the superior remaining nucleus into the inferior portion of the capsular bag, and once again use the quadrant setting to remove this portion of the nucleus. Because there is very little chatter and good adherence of the nuclear material to the phaco tip, this happens in a very efficient fashion, and the cornea is protected as I'm able to easily move this nuclear material into the central apical safe zone. At the conclusion of the phacoemulsification, I really like to use the curved IA handpiece because, of course, I can get much better access to the superior portion of the cortex under the anterior capsular flap using the curved IA handpiece. As you can see from this video, I also use a single port for phacoemulsification as well as irrigation and aspiration because of improved fluid dynamics using a single port rather than bimanual phaco. Fluid egress from the second port is of course non-existent, and there is minimal egress of fluid from the main port. At the conclusion of the cortical removal, the capsular bag is reinflated using ProVisc with attention to get good separation between the anterior capsular flap and the posterior capsule, and I introduce a model SN60WF natural lens as my lens of choice, with attention to getting the inferior haptic and optic under the inferior anterior capsular flap, and then use a Sinskey hook to place the superior haptic. After the lens is unfolded, I of course remove the residual viscoelastic with careful attention to remove all of the viscoelastic, or nearly all of the viscoelastic, to prevent a pressure spike. I tend to press down on the optic to remove that portion of the viscoelastic which is posterior to the optic, and then sweep the anterior chamber with the IA handpiece to remove any viscoelastic from the angle. After the viscoelastic has been removed, I like to hydrate my wound using BSS on a syringe, with pressing fluid into the margins of the wound as well as into the central portion of the wound to ensure a watertight seal, and conclude the procedure with subconjunctival injections of celestone and garamycin.